So our next speaker is Associate Professor Mark Sywak, a specialist endocrine surgeon focused on the treatment of patients with thyroid, parathyroid and adrenal problems. He's a graduate of the University of Sydney Medical School and a Fellow of the Royal Australasian College of Surgeons. He's the head of the Department of Endocrine and Oncology Surgery at North Shore and Clinical Associate Professor at the University of Sydney. He's got a strong interest in thyroid cancer research and is heavily involved in surgical training as the Supervisor of Surgical Training for Northern Sydney Rotation of the College of Surgeons. Mark, thank you.
Sorry. Thanks so much to Rory and Alexander for asking me to talk today. I knew that by the time I got to speak that... oh, that's the wrong one. That most things would be covered. So I'm going to have a good crack at giving Bruce Robinson's talk right now.
On the...
This one? Yeah.
No, I think yours is on the laptop. Can I just do this?
Yep. That's mine. That's
Yeah.
mine. Okay, so I've been asked to speak about surgery for high-risk disease, but in fact, I'm going to talk a little bit about the historical aspects of nuclear testing, because I was so impressed by a talk that Mike Tuttle gave us a couple of years ago that I thought it was a story that was definitely worth repeating. We'll talk a little bit about ultrasound, and I will speak about surgery. These graphs we've seen exponential rise in thyroid cancer around the world, really, and you'll note from this slide that in New South Wales, we're kind of in the top 5 precincts around the world in terms of thyroid cancer incidence. And we certainly feel that every couple of weeks when we do our thyroid cancer MDT. Lifetime risk of about 100, between 80 and 100. And Rory showed this slide. The number of actual deaths from thyroid cancer are low, but the backstory is that we have a huge number of thyroid cancer survivors who need long-term follow-up. So in that period, 1980 to 2006, there were 18,000 thyroid cancer survivors, all of whom have an endocrinologist, an annual or a twice-yearly visit, biochemistry, anxiety that comes along with all of those visits. So there's a lot of resources that are consumed and needed to maintain those patients. The thyroid cancer story is very closely linked to radiation, and we learnt this after the Hiroshima accident, but in many ways the world was a very different place after July 16th, when the Americans, as a culmination of the Manhattan Project, exploded the first plutonium bomb in New Mexico. A month later, the bomb was detonated in Hiroshima, 1945. And I think those stories are very well known, but the thing that surprised me when Mike Tuttle gave this talk was just the sheer number of bombs that were exploded in the South Pacific. And I think most Australians don't really understand that. But the Marshall Islands are just here, just south of the equator, and the Americans used the Marshall Islands as a testing site for their nuclear program during the Cold War. And you'd be surprised to learn that between 46 and 58 they exploded 66 nuclear weapons, and they weren't underground, they were into the atmosphere. And they chose the most beautiful spot, the Bikini Atoll. The most famous of those bombs was called Castle Bravo, a 15 megaton bomb. They exploded in 1954. They were really experimenting with these things, and they found out the results of this experiment really were that they created 2.5 times larger blasts than they anticipated. They irradiated a whole number of islands around it. Marshall Islanders had to be evacuated. There was a Japanese fishing trawler that happened to be going past at the same time. Most of them died from radiation sickness. It's staggering when you look at how many bombs were exploded in our backyard in that time period. So these are all atmospheric nuclear tests. Marshall Islands, 65. In Australia, we had 7 bombs exploded in Maralinga and 3 at the Montebello Islands, Mururoa and Christmas Island. I'll show you a picture of the radiation that drifted from the Fukushima accident, but there must have been significant contamination of the atmosphere in our area in those years. Chernobyl, 1986. You can see that the Russians kept it very quiet for a few days until the radiation started to head up towards Sweden, and the Swedes rang up and said, "Are there any problems down there?" And they said no, but finally they had to fess up. But the radiation ultimately spread all over Europe, and Belarus copped a big amount of it. Fukushima, 2011. This is just an illustration showing what happened when, as a result of the wind, there was actually contamination all the way across into California. Very, very mild and not dangerous, but real. So if you just look at the amount of radiation that was released in those accidents, Fukushima 4 to 5 million curies, Chernobyl 40 to 50 million, but the weapons testing in the 40s and 50s was 20 billion curies, and that was very close to Australia and New Zealand. We should be mindful of the radiation issue because, as physicians and surgeons, we do inflict a fair amount of radiation on our patients. Most of it life-saving, but it is important to be mindful of the fact that whenever we order an adult CT or a neonatal CT, we give 10 to 20 millisieverts of radiation. This is a pretty provocative paper from 2007 by Barrington, where they modelled the cancer risk associated with the use of CT scan in the US, and they calculated that just as a result of the CT scans that were performed in 2007 in the US, there were probably 29,000 cancers that were going to come as a result of that. That was a model and yet to be proven, but it just, I think, reminds us to be mindful of the fact that when we order tests, particularly CAT scans, there are consequences for patients. I'm going to take one slide to focus on the use of ultrasound, because really the quality of ultrasound in the last decade has changed dramatically. And for GPs and endocrinologists and endocrine surgeons who are dealing with thyroid nodules, we've gone beyond the point of just measuring simply the size of the nodule. We used to say if there's a nodule more than a centimetre, it needs to be biopsied, but that's no longer true. We know that these benign nodules and these very low suspicious spongiform nodules actually can be monitored and don't necessarily need to be biopsied. And in contrast, these very suspicious nodules which are hypoechoic with microcalcifications, you need to take them seriously. So if you get an FNA from a nodule like that that says it's benign, you don't necessarily always have to believe it. So ultrasound really is critical and probably our most valuable modality. I thought, rather than spend a lot of time talking about the data around surgery, I thought I'd just talk more anecdotally about the things that we've changed in surgical technique in the last 20 years. And this is a minor thing, but so important to patients, the placement of incisions. And increasingly we are attempting to use skin crease incisions in thyroid surgery. Traditionally, the incision used to be low and down here, placed in the area of a pearl necklace, but we've found that these higher incisions placed directly in a skin crease give an excellent cosmetic result and actually make the surgery a little easier because they give us access to the critical part of the operation. So you'll probably see a trend towards incisions changing flatter incisions and incisions placed in skin creases. The technology likewise has changed. No longer are we cutting and tying every single vessel. We're using these instruments, ligashore and harmonic scalpel. They allow us to be more accurate with our dissection. They actually make the surgery a little faster. Patients are on the table not as long. Complication rates are lower. The rate of hematomas following surgery has dropped. The rate of parathyroid damage following surgery has dropped. So these devices are extremely useful. Surgical technique also has advanced. We understand now that this previously really disregarded nerve, the external branch of the superior laryngeal nerve, is a very important nerve for voice quality. That nerve nowadays is recognised and preserved in over 90% of cases in the hands of surgeons with experience. We also know that if you want to avoid hypoparathyroidism, you've got to do a very careful dissection of the thyroid very close to the thyroid capsule. We understand, we've learnt about the anatomy and the blood supply of these parathyroids, and we know that if you hug the thyroid capsule here, you can drop that parathyroid down and preserve it, because hypocalcemia is actually a very troublesome post-operative complication, and it can be very easily avoided with the correct surgical technique. We've learnt a lot about how to save parathyroid tissue in cases where the parathyroid has been inadvertently devascularized. And we know that if you recognise that injury to the parathyroid early, you can mince the parathyroid up, use a balanced salt solution, cut it up into a number of tiny pieces, re-inject that into the sternomastoid muscle, and in over 95% of cases we get functioning parathyroid tissue from that parathyroid. So it's not quite zero, but the rate of hypoparathyroidism is approaching zero. You know, we're very much under 1% now. We're close to about 0.5%, and it's these tiny little incremental improvements in technique that have resulted in those good outcomes. The recurrent laryngeal nerve, as you all know, is a critical part of thyroid surgery. And up until 4 or 5 years ago, we really just used to eyeball the nerve. But now we've got a technology that allows us to monitor the nerve throughout the case. We know when we're stretching the nerve. We can learn when we're too close to it, when there's a thermal injury. I think the neuromonitor now will result in a much lower rate of nerve injury. And it's rapidly becoming a routine part of thyroid surgery. The robotic surgery is definitely here, and it is starting to find its indications in surgery. It's certainly been well proven in prostatic surgery and surgery in the oral cavity. It's still finding its place in thyroid surgery. I was in Korea last month, and the Korean surgeons are actually very expert in using the robot. Their main motivation really is to avoid incisions in the neck, and as a result they instead of putting a 4 centimetre incision in the neck, they put an 8 centimetre incision in the armpit area and tunnel up and use the robot to access the thyroid. So it's still, look, I think thyroid surgery using the robot is still in its infancy, but it's here, and there are certainly some expertise being developed in Korea, and we continue to watch that space. So what constitutes a high-risk cancer? Geoff showed this slide, but it's any thyroid cancer where there is clear invasion of tumour outside of the thyroid. If there's incomplete resection of the tumour, distant metastasis, markedly elevated thyroglobulin levels, if you have a lymph node which is more than 3 centimetres, and in the setting of follicular thyroid cancer, if there are more than 4 foci of vascular invasion. For those patients, we still really are recommending total thyroidectomy, and that's not so controversial. Where the controversies arise is how aggressive to be with the lymph node surgery. In In our experience, so this is the experience of over 1,200 cases of papillary thyroid cancer here at North Shore. If you look carefully, you'll find almost 50% of patients will have central compartment lymph node disease, not metastases died, just lymph nodes, and 20% will have lateral lymph node disease. Now, we appreciate that the presence of lymph nodes doesn't necessarily mean that the patient has a much increased risk of mortality, but nevertheless, those lymph nodes are troublesome. They cause anxiety to the endocrinologist. They cause elevated thyroglobulin levels. Geoff doesn't like it when patients turn up and there's lymph nodes all over the neck, and certainly patients experience anxiety associated with abnormal ultrasounds. So our focus has been on ensuring that when we do the thyroidectomy, at the very least we clear the central compartment. And if you use those parathyroid preserving techniques, you can do that with low complication rates. The thyroid ultrasound is poor at detecting central compartment lymph nodes, but actually quite good at determining the presence of metastatic disease in the lateral compartment. So as part of our operation for high-risk papillary thyroid carcinoma, we will routinely undertake a dissection of these central compartment lymph nodes, and it's a relatively small pocket of tissue that sits next to the thyroid and on either side of the nerve. This is a very problematic area to reoperate in if you leave lymph node disease behind, and it makes sense to clear that area out at the first operation. So an aggressive approach to lymph node really informs our endocrinologist and nuclear medicine physicians about the need for radioactive iodine. Some people are upstaged, some people are downstaged. It reduces the need for reoperative surgery, and in our hands it has certainly reduced thyroglobulin levels. When we've examined our experience here, patients who are at risk of recurrence in our hands are the very young and the very old, the 4-centimetre tumours and the poor actors, the insular and the tall cell cancers. These types of papillary thyroid cancers certainly warrant more careful attention and follow-up. Certainly the traditional markers of vascular, extrathyroidal and lymph node involvement are good predictors of recurrence, and we have been very convinced on the BRAF story, and you'll find that pathology reports that come out of North Shore always have a BRAF status. And I'll show you some data on that. Where do we fail as surgeons in papillary thyroid cancer? Well, this illustration just shows where our recurrences occur. About 8% of our patients will have a thyroid, a nodal recurrence that requires further surgery, and in most cases it's now in the lateral compartment. So our aggressive approach in the central compartment has almost entirely sorted out this area, but the lateral compartment is where we are still finding lymph nodes that need further surgery. Tracheal invasion that requires aggressive tracheal surgery actually is quite uncommon. The vast majority of our patients have this minor tracheal invasion that can be shaved off. Very rarely we're put in a situation where we've got to resect the trachea. Just to give you an idea of how often that happens, of the 34 cases of structural recurrence for papillary thyroid cancer in our experience, the vast majority were lymph nodes that could easily be managed with removing lymph nodes or injecting lymph nodes with alcohol now, which we occasionally do. Tracheal resection is pretty uncommon. Only 15% of that group needed tracheal resection, and certainly even more aggressive operations such as partial esophagectomy or laryngectomy are extremely rare. So if you're working in a practice and all of a sudden your thyroid cancer patients are coming back having had total laryngectomy or esophageal resections, it would be reasonable to ask your endocrine surgeon or head and neck surgeon whether that was really needed. We are using external beam radiotherapy more often for high-risk cancers, particularly insular carcinomas, but in general it's still a pretty low rate. The BRAF story is one that we have been convinced of here. There's a BRAF positive immunohistochemistry and a BRAF negative immunohistochemistry, and this is the survival curve, disease-free survival, and we found pretty clearly that the curves diverged. These BRAF negative patients certainly had fewer recurrences than our BRAF positive patients, and it may not just be BRAF that informs us on the genetic nature of these tumours. It might be the combination of BRAF and TERT, but I think we're not far from having surgery guided by the genetic signature of these tumours. Not all thyroid cancers can be treated surgically immediately, high-risk ones, that is, and anaplastic is one of those. This is an example of a patient who presented with an unresectable cancer at the outset. But once again, this algorithm has changed. We've now moved to avoiding surgery at the outset, pre-treating this patient with radiotherapy or a molecular agent, and then coming back and resecting something that is more likely to have a successful surgical outcome. So it's clear that the thyroid cancer burden in New South Wales is increased and across Australia. Small improvements in surgical technique over 50 years have really resulted in what in general are very, very good outcomes in terms of surgical complication rates. For high-risk cases, we are still advocating total thyroidectomy, and we are definitely moving towards a genetic signature for individual tumours that will help us guide the extent of our surgery and particularly the extent of our lymph node surgery. Thank you.